Patient's here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in emergency
in your left hand.
For 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today we're opening up a topic that I think a lot of us, especially those outside pediatrics, tend to minimize. We were talking about the pediatric gastrointestinal system. And I know the instinct is to just think, okay, tummy ache, spitting up, maybe some constipation. But looking at the massive stack of research, nursing protocols, and case studies we have for today, that feels like a really dangerous oversimplification.
Oh, it is a massive oversimplification. Yeah, in adult medicine, GI issues are often, chronic inconveniences. Things like GRD or IBS, right? Things people just live with for decades. But in pediatrics, specifically in infants and toddlers, the GI system is literally the engine of growth. If the plumbing fails, the child doesn't just get a stomach ache. They stop growing, their brain development stalls, and in several of the conditions we're covering today, they can actually go into shock and die within hours.
Wow, so the stakes are just incredibly high. We're looking at a system that is literally folding itself into existence while the baby is growing. So our mission today is to take this mountain of material, all these textbook chapters, surgical protocols, pharmacology guides, and distill it into what we call the Pareto 80-20.
Exactly. We want to identify that 20% of the pathophysiology and clinical science that will answer 80% of your exam questions. And honestly, more importantly, catch 80% of the life-threatening events at the bedside.
Right, and we have a ton of ground to cover. So we're going to start with a master map to sort of categorize these threats so you aren't just memorizing blind lists. Then we're going to do a deep dive into the specific disease processes. But here's the key shift for this deep dive. We aren't just doing the biology, we are cross-referencing every single disease with the child's developmental stage.
Which is completely non-negotiable.
Yeah.
I mean, you cannot treat a 3-week-old with pyloric stenosis the exact same way you treat a 14-year-old with celiac disease. The actual science might be straightforward, but the patient changes the entire game.
Totally. And finally, we will hit the pharmacology module, looking specifically at the mechanism of action and the safety traps for little bodies. Just a quick reminder before we really jump in. We are impartial synthesizers of the medical text provided today. We're here to help you understand the logic behind the medicine, not to provide medical advice for your specific situation.
Right. So let's get into the plumbing.
Yes, Section A, the master map.
When I first opened these files, I was just hit with a wall of Latin. Intussusception, volvulus atresia, it feels incredibly chaotic. How do we organize this mentally so that when you see a symptom, you know exactly which bucket you're playing in? The best way to approach pediatric GI is to just stop thinking about individual organs and start thinking about patterns. There are really only 4 main ways the GI system breaks in a catastrophic way. If you recognize the pattern, the intervention usually reveals itself pretty fast.
Okay, walk me through that first bucket, because this seems to be the most critical one based on the notes.
Yeah, the first bucket is the extractive emergencies. This is the something is blocked pattern. The plumbing is literally clogged. This includes hypertrophic pyloric stenosis, intussusception, malrotation, and volvulus.
So basically, food goes in, but it just can't get through.
Correct. And because it can't get through, it comes back up. But here is the single most important decision point in all of pediatric GI. If you take nothing else away from this whole deep dive, take this. You have to look at the vomit.
We're getting gross immediately. I love it. What exactly are we looking for?
Color. Specifically, is it bilious or non-bilious?
Break that down for us. Non-bilious implies what?
Non-bilious vomit looks like milk or formula or whatever the kid just ate. It might be curdled from stomach acid, but it is white, yellow, or clear. This tells you the blockage is high up. It's above the ampulla of Vater, which is the specific point where bile enters the intestine. If you see non-bilious projectile vomiting, you're almost certainly looking at pyloric stenosis.
Okay, and if it is bilious?
Bilious means green, and not a subtle yellowish green, but bright lime Gatorade green. This means the blockage is below the bile duct. Bile is being dumped into the gut, hitting a physical wall and reversing course. In a newborn or an infant, green vomiting is a surgical emergency until proven otherwise. It screams volvulus or intussusception.
So if I'm understanding this right, non-bilious is a fix-it-soon kind of problem, but green means fix it right now.
Green means run, do not walk. Because volvulus, where the bowel physically twists on itself, can kill the entire gut in a matter of hours due to strangulation of the blood supply, it's ischemic.
Terrifying. Okay, what's bucket number 2?
Missing parts or missing nerves. These are your congenital defects. The blueprint was just wrong from the start. We're talking Hirschsprung disease, biliary atresia, imperforate anus esophageal atresia.
This feels like it would be super obvious right at birth, right?
Usually, yes. The assessment priority here is the newborn period. The clock starts ticking right at delivery. The big question is, did they pass meconium in the first 24 to 48 hours? If they didn't, we start worrying about Hirschsprung's or maybe cystic fibrosis, or is their jaundice persisting way past 2 weeks? Then we worry about biliary atresia.
Got it. Bucket 3.
Absorption failures. The plumbing works. Technically, things move through just fine, but the absorption factory is shut down. Celiac disease, cystic fibrosis, short bowel syndrome.
So the kid is eating but basically starving.
Exactly. The food passes right through them. The key indicators here are failure to thrive, where you see the growth chart just completely flatten out, and stenoria.
Stenoria, that's the fatty stool, right?
Yeah, because the gut isn't absorbing fat. It just comes out in the poop. It's pale, it's bulky, it's incredibly foul smelling, and it floats. If you see floating poop in a really skinny kid, you need to think malabsorption.
And the final bucket.
Surgical inflammations, appendicitis, and mecyldiverticulum. This is less about pure mechanics and more about infection and inflammation. The key pattern you'll see here is pain migration. It starts vague and moves to a very specific spot.
Okay, that framework helps immensely. Obstructive congenital malabsorption and inflammation. Now I want to go really deep. Let's start with the condition that seems to be the classic exam topic. Hypertrophic pyloric stenosis.
Ah, yes, the case of the hungry vomiter.
Let's start with the physiology. We know it's a blockage, but what is actually happening to the stomach itself?
So the pylorus is a circular muscle that acts as a valve between the stomach and the duodenum, which is that first part of the small intestine. In these infants, for reasons we don't fully understand, though there's definitely a genetic component that muscle starts to hypertrophy, it gets really thick.
Like a bodybuilder muscle.
Exactly, like it bulks up. And as it bulks inward, the actual channel gets narrower and narrower. It typically starts causing symptoms around 3 to 5 weeks of life. And that is a key detail for exams. Babies aren't usually born vomiting with this. They're totally fine for a few weeks, and then this muscle grows enough to just shut the door.
So the door slams shut, the baby eats, the stomach fills up, and then what?
Physics takes over. The stomach is a muscle too, and it tries to push against that closed door. It contracts harder and harder. We call that hyperperistalsis. You can sometimes even see the waves on the baby's belly. Eventually, the pressure gets so high that the milk is violently ejected. And we use the word projectile very literally here. We are talking 3 to 4 feet across the room.
That is just violent.
It's incredibly violent. And remember, our map, it is non-bilious. The milk never made it past the pylorus to the bile duct.
One of the most famous findings in textbooks is the olive. Can we talk about the reality of finding this olive-shaped mass?
Yeah, the elusive olive. The textbook says you can palpate an olive-shaped mass in the right upper quadrant. This is the thickened muscle itself. But here is the absolute clinical reality. Have you ever tried to push on the belly of a screaming, vomiting, starving 4-week old?
I imagine their abs are just rock hard from crying.
Right, the rectus muscles are totally tense. If the baby is crying, you will never, ever feel the olive. You have to wait for them to relax, maybe give them a pacifier or some sugar water, flex their knees up. It requires a lot of patience. If you feel it, great, it's diagnostic. If you don't, you just send them for an ultrasound.
Now, I want to unpack the chemistry here, because the text emphasizes metabolic alkalosis. This is a huge exam concept, but I feel like people just memorize the phrase without understanding it. Walk us through the why.
Okay, let's do the chemistry. The stomach is full of hydrochloric acid. HCl, that's hydrogen, which is the H+, and chloride, the Cl-. When a baby has pyloric stenosis, they are vomiting out that acid constantly.
So they are losing hydrogen.
Right. Hydrogen is acidic. If you lose acid, your body naturally becomes basic or alkalotic. That's step 1. But there's a second hit here. They are also losing chloride. When the body loses chloride, the kidneys get stressed trying to compensate to keep the electrical charge balanced. So to save fluids, the kidneys hold on to bicarbonate, which is HCO3, and that is a base.
So you're losing acid through the mouth and holding on to base through the kidneys.
Exactly. It's a double whammy. You get a hypokalemic metabolic alkalosis. And here is why this matters so much for the nurse. You cannot send this kid to surgery yet.
Wait, really? But they have a mechanical blockage. Don't they need the muscle cut?
They do eventually.
Huh.
But if you put a baby with severe metabolic alkalosis under general anesthesia, they will likely stop breathing.
Why?
Because of respiratory compensation. If your blood is too basic, your brain tells your lungs to slow down. It says, hey, hold your breath, keep the CO2 in to balance the blood because CO2 is an acid. So these babies are already hypoventilating to compensate for the vomiting. If you give them anesthesia, which also depresses respiration, you might never get them back.
Wow, that is a massive safety flag. So the need-to-know priority isn't the surgery at all.
No, the immediate priority is fluid and electrolyte resuscitation. You absolutely have to fix the pH and the dehydration first. The surgery, the pyloromyotomy, is not an emergency. The dehydration is the emergency.
Let's cross-reference this with development. We were talking about a 4-week-old infant. Erickson's stage here is trust versus mistrust.
And this is just heartbreaking to watch. The primary way an infant builds trust is through the feeding cycle. I feel hunger pain, I cry, my parent feeds me, the pain goes away. That is the entire foundation of human trust for them.
And here that cycle is totally broken.
Completely shattered. The baby feels hunger, they eat, they vomit violently, which is painful and scary, and then they are immediately starving again. They are often described in charts as fussy or irritable, but really they are just frantic.
So what does the bedside nurse do?
Well, you have to cluster your care to minimize stress so they can rest. But you also really have to manage the parents. The parents feel like massive failures. They are trying to feed their child, and the child is basically rejecting it. You have to explicitly teach them, this is mechanical, this is not your technique, you're doing a good job, it's just a blocked pipe.
That's great context. Let's move down the GI tract to the next obstruction. Intussusception.
The intermittent screamer.
This one fascinates me because of the mechanics. The notes describe it as telescoping bowel.
Yeah, imagine you are closing a collapsible telescope or an old-school radio antenna. One segment slides right inside the other. That is exactly what the intestine does. Usually it's the small intestine sliding into the large intestine right at the cecum.
What happens to the tissue when it slides inside itself like that?
It's a complete disaster. The blood vessels get dragged in with it. The veins get compressed first because they are floppier. So blood can get in via the arteries, but it can't drain out. The bowel just swells up like a balloon. Eventually, that swelling cuts off the arterial blood supply, too.
And that means necrosis.
Ischemia, necrosis, perforation, and then sepsis.
The symptom presentation here is really specific, and I can see how it's very confusing for parents. You mentioned paroxysmal pain.
This is the absolute hallmark. The child, usually a toddler, maybe 18 months old, will be playing with blocks. Suddenly, out of nowhere, they scream, they draw their knees up to their chest and look like they're dying. It lasts for a minute or two. Then the bowel relaxes slightly, the pain stops, and the kid just gets up and goes back to playing with blocks.
That is the gaslighting part. The parents probably think, oh, maybe it was just bad gas because 10 minutes later the kid looks totally fine.
Exactly. So they wait and wait. Meanwhile, the bowel is dying inside. Eventually, those play periods get shorter and the scream periods get much longer.
Let's talk about the current jelly stool. That sounds like a classic textbook term. What does it actually look like in practice?
It looks like dark red mucus. It's not a normal formed poop at all. It is literally the sloughing off of the mucosal lining of the gut mixed with blood. If you see this, the damage is already quite significant.
Diagnosis and treatment are often the exact same thing here, right? The air enema.
Yes, this is high-drama radiology. They insert a tube into the rectum and pump air, or sometimes a contrast fluid in. The actual pressure of the air pushes the telescope bowel back out. It unfolds it.
Sounds kind of risky.
Oh, it is. There is a real risk of perforating the weakened bowel. The pediatric surgeon is usually standing right nearby just in case they need to rush to the OR. But when it works, it is instant relief.
Is there an exam trap here?
A huge one. Imagine you are prepping the child for the enema or surgery. They've been NPO, they've got their IV. Suddenly, the child passes a normal brown stool.
That seems like really good news.
It is the best news. It means the bowel spontaneously fixed itself. It untelescoped. You must notify the provider immediately because you can cancel the procedure. Do not send a kid to surgery who just fixed themselves.
Let's look at the developmental impact. We are dealing with toddlers 1 to 3 years old. Autonomy versus shame and doubt.
Toddlers are absolute control freaks. They are just learning to control their own bodies, right? Walking, feeding themselves, potty training, hospitalization strips all of that control away. You strap them down for an IV, you take away their food, you poke them with needles.
Just you see regression.
Almost 100% of the time. A potty-trained toddler will start wetting the bed again. A kid who speaks in full sentences might revert to just pointing and grunting.
How does a nurse handle that? Do we correct them?
Never. You reassure the parents. You tell them this is a normal coping mechanism and it will pass once they go home. And critically, you try to give the toddler choices where no real choices exist. Like, do you want the red Band-Aid or the blue one? Do you want to take your medicine from a cup or a syringe? Give them back just a tiny sliver of autonomy.
That makes so much sense. Okay, let's move to the congenital missing parts bucket. Hirschsprung disease.
Congenital ganglionic megacolon.
Let's break that down word by word. A ganglionic.
So during embryology, neural crest cells, which are the cells that will eventually become nerves, migrate down the gut tube from the mouth all the way down to the anus. In Hirschsprungs, they basically get tired and stop before they reach the very end. So that bottom segment of the colon has absolutely no nerves.
And no nerves means no signal to squeeze.
Correct. No peristalsis. The sphincter just stays clamped shut. Stool comes down, hits this dead zone, and piles up. It's a massive traffic jam. The colon above the jam stretches out immensely, and that's your megacolon.
In a newborn, this presents as a failure to pass meconium. But what if it's a short segment defect and they aren't diagnosed until they are, say, 6 years old? What does that look like?
These are the kids with chronic, severe, lifelong constipation. And their stools are often described as ribbon-like.
Why ribbons?
Because the only way poop can get through that tight, clamped-down, nerve-dead segment is to be squeezed completely flat. It looks like linguine. And it smells incredibly foul because it has been sitting in the colon fermenting for weeks.
There is a really specific physical exam finding mentioned in the notes. The squirt sign.
It's exactly what it sounds like. When the doctor does a digital rectal exam, the finger momentarily dilates that tight sphincter. When they pull the finger out, the pressure releases, and you get an explosive release of trapped gas and liquid stool.
The dangerous complication here is enterocolitis. Why is this the killer for Hirschsprungs?
When stool sits in the colon for too long, bacteria overgrow aggressively. The bowel wall gets inflamed and starts to break down. Those bacteria can then cross the wall into the bloodstream. If a Hirschsprung kid suddenly spikes a high fever and has explosive foul diarrhea, that is not a stomach bug. That is sepsis. It is a code-level emergency.
Developmental impact for a school-age child. Industry versus inferiority.
This is absolutely brutal for a 7 or 8-year-old. At this age, being normal and fitting in with peers is literally everything. Imagine the deep shame of having chronic constipation malodorous gas or soiling your pants at school. It's called encopresis. It's socially devastating.
And the treatment for Hirschsprungs is often a colostomy, at least temporarily, right?
Right. So now you have a child with a bag of poop on their stomach. The nurse's job is to help the child master this new reality. Industry means I can do it. You have to involve them in the care. Okay, can you hold the new bag while I clean the stoma? Moving them from being a passive victim to an active participant is crucial for their psychological survival.
Let's shift gears to the appendix. It seems simple, but it's the most common emergency surgery in kids.
Appendicitis usually hits school-age kids and teens. The pathophysiology is almost always an obstruction of the appendix lumen, often by something called a fecalith.
A fecalith is, wait, is that a stone made of poop?
Essentially, yes, a calcified poop stone. It blocks the opening. The appendix keeps secreting mucus because that's what it does. Bacteria multiply, the pressure builds up, and the wall starts to literally rot.
We talked about pain migration earlier.
Right, it starts periumbilical, just vague pain around the belly button. Over 12 to 24 hours, it migrates to the right lower quadrant, specifically McBurney's point.
And the physical exam.
Rebound tenderness is key. You press down slowly on the abdomen and the kid grimaces. But when you let go quickly, they scream. That is the inflamed peritoneum snapping back against the swollen organ. Also, look at how they move. They will be walking hunched over. They won't want to jump or climb up onto the exam table.
The sudden relief sign. The notes say, this is the biggest exam trap.
It is so counterintuitive. If a child has been in 10 out of 10 pain for hours, crying, inconsolable, and suddenly says, hey, the pain is gone, I'm actually hungry, you do not celebrate.
Why?
Because the appendix just ruptured, the intense pressure is released, just like popping a balloon. But now all that infected pus and stool is freely spilling into the sterile abdominal cavity. The pain relief is very temporary. In a few hours, they will have a rigid, board-like abdomen and massive peritonitis.
So sudden relief equals a rapid response.
Yes. Keep them. NTO, start 4V antibiotics immediately and prep for emergency surgery, and absolutely no heat pads.
Right, because heat brings blood flow.
And can hasten the rupture. Ice is fine for comfort. Heat is strictly forbidden.
Let's move to the absorption bucket. Celiac disease. This isn't just a trendy lifestyle diet, it's an actual autoimmune disaster.
Correct. In celiac, the body views gluten, which is a protein found in wheat, barley, and rye, as a dangerous foreign invader. The immune system attacks the gut lining, specifically the villi.
I really love the analogy you used in the pre-show notes. The shag carpet versus the tile floor.
It's the best way to visualize what's happening. The small intestine is lined with villi, millions of tiny little fingers that stick up. They increase the surface area so you can absorb nutrients. A healthy gut is a thick shag carpet, plush, deep, tons of surface area. In celiac, the immune system essentially hacks all those villi down. The gut becomes a flat tile floor, smooth, flat, and completely unable to absorb nutrients.
So the kid eats the food digests, but the nutrients just slide right across the tile floor and out the back door.
Resulting in steatorrhea, that fatty foul stool, and severe malnutrition. You see a really classic look. A child with thin-waisted buttocks and limbs, but a huge distended belly due to the fermentation of all that unabsorbed food.
The crisis. What exactly is a celiac crisis?
This happens mostly in very young children. It's profuse watery diarrhea and vomiting, leading to severe dehydration and metabolic acidosis. It looks exactly like sepsis, but it's triggered by a massive gluten exposure or sometimes a secondary infection on top of the untreated disease.
And the management is strictly diet. The acronym is BERO.
PO, barley, rye oats, and wheat.
Let's talk about oats for a second.
Oats are the really tricky one. Technically, pure oats do not contain gluten, but they're almost always processed in the exact same mills and factories as wheat, so cross-contamination is rampant. Unless the box specifically says certified gluten-free oats, they are strictly on the no list.
Developmental nightmare here is adolescence rape.
Teenagers are just trying to establish their identity. They want to be exactly like their friends. Celiac makes them inherently different. They can't eat the pizza at the party, the birthday cake, the late-night fast food.
So they cheat.
They cheat all the time. They think just one slice won't hurt. And in celiac, the symptoms might not be immediate, like a peanut allergy anaphylaxis. They might not feel violently sick until the next day, or they might just get silent damage to their villi. This makes compliance incredibly hard. The nurse really has to negotiate here, not dictate. Connect them with peer support groups or smartphone apps that find safe restaurants. You have to give them tools that fit their actual adolescent life.
Let's dive into the core add-ins from the standards. Cleft lip and palate.
Right, these are facial fissures affecting feeding and speech. Pathophysiology is a failure of fusion during embryonic development.
What's the priority assessment here?
You must palpate the palate with a gloved finger. Visual inspection just isn't enough to rule out an occult cleft palate.
And for feeding, because they obviously can't create suction.
We use special nipples like the Haberman feeder. You feed them upright, and you have to do frequent burping because they swallow massive amounts of air. But the real exam focus is post-op care. You must protect the suture line.
How do we do that with a baby who constantly puts their hands in their mouth?
Elbow restraints. We call them no-nos. They keep the arms straight so the hands can't reach the face. And absolutely no spoon straws or pacifiers post-op.
And developmentally, this impacts speech and bonding, right?
Yeah, high risk for speech impediment, so early referral to therapy is key. And nurses must assess parental bonding. There can be real shock or grief over the facial appearance, and we have to support the parents through that.
Another core add-in is esophageal atresia and TE, Tracheoesophageal Fistula.
The plumbing is totally crossed here. The esophagus ends in a blind pouch, and the trachea connects directly to the stomach.
That sounds immediately lethal if they feed.
It is. The exam classic is the 3 Cs. Choking, coughing, and cyanosis with the very first feed. You also see excessive drooling in a newborn because they literally cannot swallow their own saliva.
Intervention.
NPO immediately. Constant suction of the pouch. And elevate the head of the bed to prevent gastric juices from refluxing up the fistula into the lungs, which causes severe aspiration pneumonia.
Moving on to Meckel diverticulum.
A leftover pouch near the ileum from embryology. The key symptom is completely painless rectal bleeding, often brick red or currant jelly. We diagnose it with a Meckel scan. It's a bleeding risk and can also lead to intussusception.
And the last disease, GER versus GUR.
GER is gastroesophageal reflux. This is your normal happy spitter. They spit up, but they are growing fine. It usually resolves by 12 to 18 months. GER with a D for disease is pathology. The infant fails to gain weight, has respiratory issues or apnea, and classically they arch their back during feeds because of the acid burning the esophagus.
Intervention for GER.
Thicken feeds with rice cereal, keep them upright 30 minutes after feeds, and use meds like PPIs.
Speaking of meds, let's transition to Section C, the medication module. We have a few key drugs here, and I really want to focus on the safety protocols.
Let's start with pancreatic enzymes, pancrelipase, used primarily for cystic fibrosis.
Right, the pancreas is blocked with thick mucus, so we have to replace the enzymes manually. How exactly do we give it?
The golden rule is if they eat, they treat. These enzymes must be in the stomach at the exact same time as the food.
So snacks too.
Every single meal, every single snack. If a kid eats a handful of pretzels, they take enzymes.
What if the kid is a toddler and can't swallow pills?
You open the capsule and sprinkle the little beads on something acidic like applesauce. But here is the exam warning. Do not ever sprinkle it on alkaline food like milk or yogurt. If you do, the enzymes will activate right there in the mouth and literally digest and burn the oral mucosa. And you must tell the child not to chew the beads. Just swish and swallow.
How do we know if the dose is actually right?
The poop check. If the dosing is correct, the stool should look normal. If the child still has steatorrhea, you need to call the provider to increase the enzyme dose. The poop tells the truth.
Let's talk about vitamins for these kids.
With cystic fibrosis or biliary atresia, you have massive fat malabsorption. So they need the fat-soluble vitamins A, D, and K. But the Pedi pearl is they must be in a water-miscible form.
Because they can't digest the regular fat version.
Exactly. If you give standard vitamin D drops suspended in oil, they will just poop it straight out. It has to be the special water-soluble formulation. And watch for deficiencies like bleeding for vitamin K or rickets for vitamin D.
Next, drug gentamicin, often used for ruptured appendix or peritonitis.
A very heavy hitter antibiotic. It's an aminoglycoside. It clears gram-negative bacteria beautifully, but it has an incredibly narrow therapeutic index.
Meaning the difference between cure and poison is super small.
Very small. It is highly nephrotoxic, damaging the kidneys, and ototoxic, damaging the ears.
How do we monitor that safely?
We draw peak and trough blood levels. The trough is the most crucial one. That's the lowest level right before the next dose is due. If the trough is too high, it means the drug isn't clearing, and the kidneys are basically soaking in toxin.
Not in the ears.
It permanently kills the hair cells in the cochlea. If a child on gentamicin says, "My ears are ringing," you stop the infusion immediately. Tinnitus is the final warning shot before irreversible deafness.
Next is nystatin for thrush.
We talked about this antifungal. The key pearl is contact time. Nystatin is not absorbed systemically. It only works by physically touching the fungus.
So swish and swallow.
Yes. And for little babies, you physically paint it on the white patches with a Q-tip. But critically, give it after the feeding. If you give it before the milk just washes it right down, you want it to sit on the tongue and cheeks for as long as humanly possible. And educate parents to boil pacifiers to prevent reinfection.
Finally, PPIs like omeprazole or H2 blockers like ranitidine.
Used for severe G. irritae, the timing here is the exact opposite of enzymes. You want to give these 30 minutes before feeding, usually in the morning. The drug needs time to get into the system, find the acid pumps, and physically shut them down before the food hits the stomach and triggers acid production.
Okay, we have the maps, the diseases, and the meds. Now I want to do a final synthesis. We call this the matrix. I'm going to throw a symptom scenario at you, and you give me the decision path.
I'm ready. Let's do it.
Scenario 1, a 4-week-old. Projectile vomiting. Hungry immediately after.
Pyloric stenosis. Check for the olive mass in the right upper quadrant. Check the blood gas for metabolic alkalosis. Correct fluids first, then send for surgery.
Scenario 2, an 18-month-old. Screaming intermittently, pulling their legs up to their chest, then acting totally fine.
Intussusception. Look for current jelly stool. Prepare for an air enema. Watch closely for a normal brown stool, which indicates spontaneous resolution.
Scenario 3, a newborn. No meconium at 48 hours. Abdomen is distended.
Hirschsprung disease. Crucial safety point, do not do a rectal temp because of the risk of perforation. Prepare for a rectal biopsy to confirm a ganglionic cells and then surgery.
Scenario 4, a 10-year-old. Pain started at the belly button, moved to the right lower quadrant, walking hunched over.
Appendicitis. Keep them NPO immediately. Absolutely no heat packs. If the pain suddenly stops, assume rupture peritonitis and call the surgeon immediately.
Scenario 5, an infant with jaundice past 2 weeks. Stool is white like clay. Urine is dark like tea.
Biliary atresia. This is a liver emergency. They need the Kasai procedure ASAP to prevent permanent cirrhosis while they wait for a transplant. We might use ursodiol to improve bile flow in the meantime.
That recap is just pure gold.
It's the 80-20 right there. If you know those, you are safe.
Before we sign off, I want to circle back to a thought you had in the notes. Your folded tube concept.
Oh, the embryology.
Yeah.
Yeah.
We talked about cleft lips, esophageal atresia, imperforate anus. They are all midline defects.
It really gives you a profound sense of humility about the human body. We all start as just a flat, tiny disk of cells. In the first few weeks of gestation, we fold longitudinally to make a tube, which is the gut, and we fold laterally to close the chest and the belly. It's like incredibly complex, microscopic origami.
And if the paper slips even a millimeter.
You get a fistula, you get an atresia, you get a cleft. It highlights that pediatric nursing isn't just fixing leaks, it's helping a child and a family navigate a structural error in their very blueprint. It's about ensuring that despite the plumbing issue, the child can still achieve their full developmental destiny.
That is a beautiful place to leave it. You have the science, you have the safety checks, and you have the developmental soul of the care.
Now go ace the exam.
And go save some little lives. Thanks for diving in with us.
Until next time.